Well, it is 2 o'clock and we're going to begin. Good afternoon, everyone, and thank you for attending this special web event for diabeteshealthequity.org in recognition of National Diabetes Month. This project is made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and the Bristol-Myers Squibb Foundation's Together on Diabetes initiative. Well, I am very excited to welcome you to this National Experts Panel discussion entitled Achieving Optimal Integration of Clinic and Community Interventions in Diabetes Care. Today's moderator is Dr. George Rust, Professor of Family Medicine and Co-Director of the National Center for Primary Care at Morehouse School of Medicine. And our distinguished guests are Dr. James Gavin, Chief Executive Officer and Chief Medical Officer of Healing Our Village and Clinical Professor of Medicine at Emory University, and Ann Albright, PhD, Director of the Division of Diabetes Translation, National Center for Chronic Disease Prevention and Health Promotion at the Centers for Disease Control.
Now, I'm not going to go into a lot of detail on the statistics of disparities, but I wanted to show this one slide to demonstrate two things. One is that the disparities are persistent and pervasive, and they've been around a long time. But the other thing I wanted to point out with this slide, which shows disparities in diabetes-related end-stage renal disease over the past decade, that the resolution of disparities is possible. Disparities are not inevitable, but health equity is achievable. If you look at the curve for American Indian and Alaska Native individuals, we'll see that there's a significant decline in end-stage renal disease. The gap is closing. That population and other population groups achieving better outcomes. So we're here today to talk about disparities as a problem, but more importantly, to talk about paths to health equity, believing in our heart of hearts that health equity is achievable. Now, there's a lot of things that drive health disparities. We're going to talk about those today with our panelists. It is not just one thing. It's not just access to care, but access to care, health behavior, self-management, self-efficacy, poverty, social determinants, all these things involved in causing contributing to health disparities. So what we're going to talk about today is a fairly simple model that tries to address all of those things. That you can do things in the clinic to improve outcomes and care, but you also have to do things where the free range people's homes, communities. You have to be able to tell whether what you're doing is making a difference in outcomes. We have this paradigm of a three-element model: clinic, community, and outcomes. And probably the most important things on this slide are not the red boxes, the three elements, but the arrows between the elements, that we have to do clinic and community at the same time, together in a collaborative mode. We have to have the outcomes feeding back to both the clinicians and community folks in ways that make sense to them, help them understand what they're doing is making a difference. So that's the framing of this, that disparities are not acceptable, that equality is achievable, and that to get there, we're going to have to do clinic, community, and outcomes all at the same time, all in a comprehensive, collaborative, systems feedback kind of model. And because I'm not smart enough to do all that by myself, we have some extraordinary national experts on the panel with us today. Let me introduce them at this time. Jim Gavin. James Gavin is Chief Executive Officer and Chief Medical Officer of Healing Our Village Incorporated in Georgia, a company that specializes in targeted advocacy, training, education, and outreach for healthcare professionals. He's also a clinical professor of medicine at Emory University School of Medicine and at Indiana University School of Medicine in Indianapolis. Dr. Gavin is also chairman of the board of Partnership for a Healthier America, an independent not-for-profit group working with the private sector to reduce childhood obesity. Early on, Dr. Gavin earned a PhD from Emory University, and MD from Duke University. So, some academic chops there. He served as Senior Scientific Officer of the Howard Hughes Medical Institute and directed their Research Scholars Program for decades. I came to know Dr. Gavin during his president of the Morehouse School of Medicine and been a friend and mentor ever since. Oh, by the way, he makes some really cool stuff in his woodworking shop. Dr. Gavin belongs to many, many organizations, has received numerous awards, but he is on the Institute of Medicine, Science, American Association of Clinical Endocrinologists, American Diabetes Association, which he's a past president. He's authored or co-authored 225 articles, abstracts, editorial boards. Just an amazing gentleman who has a positive and optimistic spirit, all wrapped around an incredible mind, an incredible heart. In addition, today we have Dr. Albright, who is director of the Division of Diabetes Translation at the National Center for Chronic Disease Prevention and Health Promotion. Dr. Albright assumed that position in January 2007. As director, she leads a team of more than 100 professionals who strive to eliminate the preventable burden of diabetes through leadership, research, programs, and policies in practice. Dr. Albright received a doctoral degree in exercise physiology from the Ohio State University. She completed an NIH postdoc fellowship in nutrition at the University of California, Davis, and a clinical internship in nutrition at the University of California, San Francisco, and served as chief of the California Diabetes Program for the California Department of Health Services. She also has served as the Senior Health Policy Advisor in the Office of the United States Surgeon General. And she led the Secretary of Health's Diabetes Detection Initiative. She's well known for her work on diabetes, including the implementation of evidence-based diabetes care guidelines, and works on models of care in community clinics, application of diabetes prevention, and development of campaigns to increase understanding of diabetes and the importance of blood glucose, blood pressure, and lipid control. So an extraordinary expert. She served in key leadership roles with the American Diabetes Association, the American College of Sports Medicine, American Association of Diabetes Educators, and the American Dietetic Association. So with that, we have an incredible group of leaders in the room with the power to both teach us and to implement change and to tell us what's working around the country. With that, I turn it over to Dr. Jim Gavin.
Thank you very much, George. It's a pleasure to be here and to share in this discussion with you and my colleague, Dr. Albright. And I'm going to put in frame my contributions to this, if I can get the slides to advance. The relationships that currently are suggestive of community-based interactions that characterize this rapid cycle response that Dr. Rust has introduced. These are my disclosures, which you have seen on the screen here. And let me put this in perspective by pointing out first, next slide, the questions of how do disparities arise? Well, we're talking about differences in the quality of care that's received within the healthcare system. We're talking about issues related to differences in access, and these are things that Dr. Russ has already alluded to, especially preventive and curative services. But then we're also talking about the broader mix of differences in life opportunities, exposures, and stresses that result in differences in underlying health status. And it's important to keep in mind that when we talk about racial and ethnic disparities, there's a fundamental difference in health and health status. So when we talk about health status, we're really talking about the consequences of these differences that express themselves as differences in penetration and prevalence rates and the incidence rates of certain disproportionately influenced conditions. For example, African Americans and the extent of HIV/AIDS in the population, American Indians, Alaska Natives, who are 6 times more likely to die from TB, the disproportionate impact of diabetes in Latinos and other communities of color. And we're looking at South Asians who have 4 times the risk of death related to heart disease compared to other ethnic groups. when we talk about ethnic disparities related to health, there we're talking about the issues that relate to the impact of the system that is responsible for delivery of services that help with prevention, that help with improvement of outcomes. So we're talking about the fact that there are more medical errors with negative clinical outcomes, that even among insured communities of color, they're less, these people are less likely to receive preventive health services. For example, African Americans are especially are twice as likely to utilize emergency room services than non-Hispanic whites. And when we look at disparities in health and health care, we're looking at differences in the use of medications for things like asthma, cardiovascular disease, and mental health illnesses, and that 51% of the transplant waiting list are from people from disproportionately affected racial and ethnic groups. Now, chronic diseases, of course, present a particular problem because this is what accounts for the majority of the morbidity and the mortality in this country. These are the conditions that are the core elements of the three that account for the $3.8 trillion healthcare budget in this country. And there are conditions that often result from the inadequate use or the failure of earlier use of these of the interventions that are designed to prevent progression, if not the onset of preconditions to full-blown conditions. Examples include prediabetes, mild hypertension, overweight, and early obesity, dyslipidemias, and so forth. And then we have often failed to adequately translate the evidence from research into policy or practice that can leverage community-based interventions in these high-risk groups. This is nowhere truer than with diabetes, which is clearly known to favor minorities. And what I mean by that is that it doesn't do us any favors. It's just that it certainly appears in a disproportionately high rate and has a disproportionately high level of impact. Examples of the disparities in diabetes care will be represented in the following two slides. And what you see here are the frequencies of three core evidence-based tests that can influence diabetes-related outcomes. We're talking about testing for A1C, eye exams, and foot exams. And these are clearly tests that, when done with some degree of regularity, can prevent diabetes-related outcomes. What you see here is that blacks are less often than whites to get these core tests. Hispanics are less often to get these tests than whites. And then it doesn't matter what your race or ethnicity might be. If you are poor, you are less likely to get these tests, and if you have less education. So poverty and poor education trump all other elements with respect to the likelihood that you will not receive these evidence-based tests that are known to prevent untoward outcomes in diabetes. And then when you look at hospital admissions for short-term complications of diabetes, you find that by far blacks exceed other groups in terms of the frequency of those kinds of admissions. Clear evidence of disparities. Now, what are the strategies that can help us remove some of the barriers that are contributing to these outcomes? Well, we need to encourage patients to participate in effective programs, disease-specific education, and disease-specific support services. Partnerships are essential, and we need to pull all of the elements of community together in these partnerships. Churches, housing authorities, social service organizations, parks and recreation departments, employer groups. And we need to advocate for policies that will improve care in all sectors, whether it's at home, whether it's at school, or whether it's in the workplace. And these partnerships are diverse. The elements of this partnership must cover all of the fronts, whether we're talking about public sector partnerships with the private sector, contributors from the food industry, urban planners, churches, schools, community groups. This is what we mean by community, and this is the core of what those partnerships must look like. Now, does it work if we are able to pull these partnerships together? The next slide shows what has happened in a project in San Diego County called Project Dolce. Dolce, of course, is a Spanish word for sweet. This looks at community-based efforts where hospitals, county health department, the School of Public Health at the university, the School of Medicine, and local healthcare foundations, elements that are present in many communities, including our own here in Atlanta. They combine forces with community health partners, community health improvement partners, the Council of Community Clinics, the Whittier Institute for Diabetes, and they use a series of clinic-based design teams. And what they were able to do is to, using a chronic disease model that's shown in the next slide, they were able to show that when you take the elements in the community, when the county as a community government representing the community adopts a model for community-based interventions, and the clinics sponsor and implement that model, now the health system collaborates in a comprehensive way so that there is a change in delivery system design with nurse-led teams and working with primary care folks, decision support teams that changed the standards of care. And then they had a way to catch and archive and use the data by using an electronic-based record system that captured all of the outcomes data. And when they were able to form partnerships with this kind of network, pulling all of the elements together, they had improved outcomes that are shown in the next slide. For example, at the 1 year mark, there was clear reduction of A1C, lipids, and blood pressure. The project absolutely contributed to improved outcomes across the board in metrics that are important in diabetes. And in the next slide, what you see is that among those elements of care that are evidence-based, that can reduce and prevent outcomes in diabetes, for example, foot exams, A1C, and eye exams that we talked about that were clearly evidence of disparities in communities of color, you see there was a threefold increase in foot exams, a substantial increase in A1C testing, and a huge increase in the percentage of people who were getting eye exams. The kind of partnerships that we're talking about can work. Now, we are doing that here. Our company, Healing Our Village, is doing community outreach program in a Medicaid managed care setting, in an urban setting where we used similar kinds of collaborations and partnerships, connecting those key elements. And what you see here is that before the intervention and after the intervention, there was vast improvement in A1Cs, in blood pressure, in lipid profiles. And just as important, not more important, but just as important, there was significant cost savings. Emergency room visits virtually disappeared. This is one of the kinds of things that we'd like to see when we are seeing disparities disappear. And so successful strategies to improve diabetes outcomes in African Americans and Hispanics exist. And if we look at examples where we're using social networks, involving family members, peer groups, churches, one-on-one interactive educations with community health workers and the like, culturally tailored interventions in education, appropriate sensitivity to diet and language, social norms. These are the kinds of things that can actually help reduce these disparities, and it's important to emphasize cognitive behavioral education, self-care management, and adaptations of research-based findings, such as the diabetes prevention program, with a focus as well on improving the ability of people to adapt to the stresses that are inherent in chronic disease management. And finally, if you look at the question of, can it work at the ground level in places like churches? Well, here in Atlanta, there was a community-based African-American church initiative that used the evidence from the diabetes prevention program to set up a self-management program for its church members. And as a result of using that intervention, where they worked with clinics, they worked with education programs, they were able to show lowering of fasting glucose, lowering of weight, lowering of A1Cs, and improvement in diabetes-related quality of life. And this is what I want to show as a bottom line. When they were trying to achieve weight loss in these congregants, this is one of the most difficult needles to move. What you see here is that 48% of the participants lost at least 5% of their baseline body weight. 26% lost 7%. And an amazing 14% of the participants lost 10% or more of their baseline body weight. And with that, all of their other metabolic metrics for their diabetes improved, and they felt so much better about themselves. All because of the connections and the integration of these partnerships. And so I leave with you the fact that we need these partnerships. We need to have them effective. We need to have them continuous, and we need to be utilizing the learnings that we derive from successes that we enjoy. And I've only pointed out a few of them. There are plenty others.
Well, thank you, Dr. Gavin. You covered some wonderful territory there, and what comes through for me is the optimism and seeing that things can really work, that we really can change, we really can move the needle. Well, another world-changing needle mover is Dr. Ann Albright, who's over at Center for Disease Control and Prevention, and will be joining us from that location today. But Dr. Albright will be speaking to us also about what's working from CDC's perspective in terms of integration of community and clinical interventions to achieve diabetes health equity. Dr. Albright?
Great. Hi, everybody. It's really a pleasure to be with you. So much that we can talk about, and just a ton that needs to be done. I'm going to pick up on a few themes that you've heard today. And so hopefully you will actually hear some of the similar points being emphasized. I think that's usually a good sign that we are needing to identify some common themes, and obviously there's so much more that we need to do. So the first slide, these are my disclosures. I really don't have any disclosures as an employee of the federal government, but I'll move to the next slide if we could. I wanted to hone in on this diagram for just a bit to make a few points. And again, some of this you will have heard from Dr. Gavin and Dr. Rust as well. There are many, many things that we can and should be doing to achieve health equity in diabetes. It's a question of how do we focus? Where do we focus? Where are the major issues? Where are the concerns that we have? One of those drivers, or a major driver for that, is understanding the population. You just heard a number of the statistics presented. Much of that comes from CDC. We manage the nation's surveillance system for diabetes. There are a lot of positive elements to those surveillance data. There are also some real gaps, and no doubt many of you have noticed some of those gaps. We'd like to have even more detailed data on some subsets of the population, but we've been taking great efforts to try to be able to dig deeper into those data, to try to be able to offer information broken down by race, ethnicity, by socioeconomic factors, by age, by location. When we look at something, I'm going to hone in on one of the partnerships, and Dr. Gavin did a wonderful job of emphasizing how critical partnerships are for us to addressing equity. This is one very critical partnership that I think encompasses a number of elements. This community clinical partnership. It's one that's getting a lot more attention these days, fortunately. And let's take a look at each of these elements of this partnership. We can take this to look at diabetes from the whole. There are things that impact the whole population. You know, we'd like to keep everybody from even becoming high risk and ever having to worry about diabetes. There are things we need to do with pre-diabetes, those we need to do who have diabetes, and certainly those that are now experiencing the serious complications from diabetes. So if we look at some of the things that go on, let's take the community side of this initially. So we're still back on that original slide. So we're going to look at the community side here. there are various research studies going on. A number of these things have been identified as a result of research and data that comes from this work. Things looking at healthy public policy. Some of you may certainly be advocates and champions for some of those healthy public policies that are going on, changing that built environment. Things related to sugary beverages, things related to safe places for being physically active, things going on in housing developments. There's the opportunity to examine and study those interventions. We need to use different kinds of methodologies to study those. We're doing a series of natural experiments right now at CDC with many of our partners around the country, looking at some of these kinds of things. We're examining some aspects of what happens when you link electronic health records to referrals to prevention programs out in the community. That's going to allow us to do a better job of identifying those within these systems and how to help get them connected to the services in their community. So again, this community side has a number of studies that can and should be going on, that we really do need to understand how effective those are if we're going to prioritize them and be able to really hone in and further refine and define what's effective in addressing these disparities. And then we'd like to take a look at the clinical side. Dr. Gavin actually presented that chronic care model. These should look very familiar. Prepared, proactive practice team, decision support, information systems, informed, activated patients. There are a number of research studies going on, real life practical research studies going on in this area that we need to, again, better understand. One of the things we're examining is what impact do high deductible health plans have on people with diabetes? Are they impacting some populations more than others? So it's important that we, again, study and examine those and evaluate them effectively. And look at that big chunk in the middle that we need to be working on together. There needs to be much more of that. There needs to be much more ability for the entities that are out in the communities where people live and work and worship and play, connected to what's going on where people do get their health care. These are not separate endeavors. These are the same people going to all of these various avenues and locations. So a lot of opportunity, and underscoring all of this is the surveillance data. If I could see all of you, I'd ask you to raise your hands. How many of you have looked at or seen those CDC maps, the ones that show what's been happening to the prevalence of diabetes across the country? I hope if you haven't, you will look at those. Look at our county maps. You'll see where there are hot spots around the country. We now have a diabetes belt along with the stroke belt. So it's this whole combination of various kinds of research, various pieces of information that we need to look at and look at in their real context, in their true context, to be able to do things like enhance and expand this community clinical partnership if we're really going to be addressing these health equity issues. Next slide. So by way of example, let's take a look at some data that we published not all that long ago, just came out this year. How are we doing in reducing those dreaded complications of diabetes? Well, you take a look at this slide, it looks pretty encouraging. By and large, these are moving in the right direction, and that is encouraging. And I think we should take a moment and all really applaud that. This is because there are better use of medications, technologies, nurses, other practitioners, a variety of people who are now engaging in the team care approach. Are we where we need to be? Not by a long shot. We have a lot more to do. These data, by the way, represent the average person with diabetes. When you look at this data by race, ethnicity, these improvements are probably by about half as much as they are for the predominant population when compared to non-Hispanic whites. So even though they're moving in the right direction for all these populations, they are not moving as great a rate or as significant as an outcome. So it is important, again, to look at these surveillance data, determine how well we are doing, and to monitor our progress. And so in the area of, again, the most significant complication, heart attack, We've been seeing the biggest improvement in that. That tells us that many of the things we're doing in hypertension control, lipid control is effective, but we still have a long way to go. But I hope that that gives us both encouragement and it gives us a call to action to continue to really hone in on some of these kinds of interventions and endeavors that Dr. Gavin has described. And I was sharing one with you as well to underscore the prevention. So it is important to take a look at these things that are working, how well they're working, and then we need to be replicating and scaling those that are most effective. Let's move to the next slide. I love to call this, I'm a big music fan. I love the blues, I love rock and roll. So here's an example, I'll call this the stairway to heaven. This is the stairway that gives us the chance to walk along from basic science. And you can see that's really the underpinning for all of this. We really need to be sure that we are having good basic science. For those of us with diabetes, we're alive today because of these discoveries. They're imperative. However, we can't stop at the bottom stair in the stairway. We have to climb all the way to the top. When we look at the next step in the stairway, these are those efficacy trials, those studies that give us a sense of, can you even do something in an ideal setting? It's proof of concept. Is it even going to work? The Diabetes Prevention Program research study is a good example of that. From that research and many other of those randomized controlled trials, we learned that you can indeed prevent or delay type 2 diabetes. And the outcomes from that trial demonstrated that it could be done in all of the racial ethnic groups and genders and ages that were studied in that research clinical trial. That's very encouraging. So that's, again, another important step. We move to the next one in the stairway, which we call effectiveness studies. Can you take those things that you did in an ideal setting and can you now do them in the real world? What happens when you take those things out of that pristine setting where you've got highly credentialed people, very capable, lot of resources? What happens when you try to take that evidence and put it in place in the real world? Many times, darn, it doesn't just automatically move into the real world. There requires additional research. There require more things that have to be done in order to accomplish that. Now we get to the upper three stairs in the stairway. And this is oftentimes where we tend to falter. And if we falter here, we have done a disservice to the entire investment that's been made in those previous three stairs in the stairway. And so it is important that we go now to efficiency, availability, and distribution, meaning we now need to get the biggest effect we can on the most people. We need to be sure that there's an adequate supply. It's not going to be good enough if we've come up with something that works, but we can't get it to the people who need it, or we don't have enough of it to get it to the people who need it. And then we move to that last step, this distribution. Are we really getting it to all the people who need it? And this is, again, where equity comes shining through. If we have these wonderful discoveries, and we do have many of them, in a lot of cases, we do know what's effective and we do know what to do, but we have not scaled it enough and we have not put it in place in a way that allows sustainability. It's not enough to come up with these things. They really do, again, have to reach that wide array of people where they are, where they can access it, and then they also have to be able to be, again, sustainable, or we will continue to keep cycling through these problems. Next slide. I'd like to close by way of an example, and that is the Diabetes Prevention Program. Dr. Gavin and I have both mentioned that study. It is the most predominant study, the most prominent study on demonstrating that you can indeed prevent or delay type 2 diabetes in those at high risk. Again, there are a number of things we need to do to keep people from ever becoming high risk. We're very hopeful and continue to examine those, again, environmental strategies, those whole population approaches that will raise the health of everyone. We are hopeful that that will indeed keep people from even moving into the pre-diabetes pool. And certainly those environmental changes will help those who are in the pre-diabetes and diabetes pool be able to be more effective at caring for themselves because they're not being in an environment that is so hostile to good health. In the case of the diabetes prevention trial, again, it was effective in all the populations studied. There have now been a number of translational studies, those real world studies in that stairway to heaven. We've done a lot of work with a variety of groups around the country to demonstrate that indeed you can roll this out in the real world. And now what we're doing as a result of the Affordable Care Act in 2010, Congress authorized the CDC to establish and manage the National Diabetes Prevention Program. We call it the National DPP. And in short, these are the 4 components of that program. There is a training component, so we are bringing in trained lay workers in addition to the myriad of health professionals who have to be involved in this. This is an all hands on deck. This is our chance to really come together and organize ourselves in a cohesive way to implement this intervention that is not a one-size-fits-all intervention. It is an intervention that sticks with a set of parameters that can indeed be a bit individualized and customized to address people's personal choices and their concerns and their issues, but it keeps us all at least on the same playing field so that we can actually see the kind of movement we've got to see in order to, again, address equities and to raise the health of everyone in the country. So these 4 components are intended to do that. We are looking to have coaches who represent all walks of life. They need to be anchored to organizations who represent all facets and stakeholders in society. So we have coaches that come from, again, healthcare facilities, that come from community organizations, from churches, from universities, from cooperative extensions, from Lions clubs, from all different kinds of places, but they're anchored to organizations who come into what's number 2 in this undertaking is quality assurance and a recognition program. CDC has set basic standards with a lot of public input so that we all, again, can be playing off the same scorecard here. We can really get together around a common set of metrics so that we're all measuring effectively together. The third is the actual intervention sites themselves. And we, along with a whole bunch of partners and stakeholders of all kinds and shapes and sizes, have come together to actually implement this program. You heard Dr. Gavin mention churches. It's going on there. It's going on in community health centers. It's going on in, actually, there's a program being delivered by the YMCA in the boardroom of a Ford dealership. Anywhere you can have these locations where people can congregate, you can have the program delivered by an organization that can meet the standards so they have the infrastructure to do it. CDC provides technical assistance to do that and seeks to help people to do that, and we provide that, again, at no cost. That's a part of what we feel is our role to offer to the public. We are also now going to be allowing those organizations who deliver the program virtually to come in for recognition. So that will also give many more people access, whether it's in public libraries and a variety of other places. And then finally, the last one is health marketing. And this is where we all can play a role. Wherever you work and play and worship, wherever your sphere of influence is, we really need to be marketing this work together. Again, really pushing hard on getting some of these very well proven interventions implemented to scale and to be sustained so that we can actually, again, get to the top of that stairway and really address these health equity issues and really implement the research that we have done. And by the way, the recognition program, because it allows us to collect data, we will be in this continued ability to evaluate and determine how effective we are all being at scaling this intervention. And this is just one example of an effective intervention that we really have to take by the horns and give a full court press to get this implemented. So let me close with this last slide. And this is to leave you with some information about considering a model for social change, because that's what we're all trying to do. We are trying to improve health, but because our health is so infused into those social determinants, and it's so infused in where we live and where we work and where we play and worship, that we do need to think about how do we come together in this united way, still bringing our perspectives, our differences, our uniqueness to all of this. But this is just one model that has been shown to be helpful and effective to think about bringing together all these kinds of partnerships. And these are some of the elements of that model. You have a common agenda. That means there can be, again, all kinds of other things we need to work on, but when you're coming together as coalitions, as community members, and you want to be working on some of these things and you identify what it is, and we'll just again take the example of diabetes prevention. The National DPP allows us to have a common agenda so that we can, again, organize ourselves. The recognition standards allow us to have a shared measurement system so that we can have a common set of metrics that we can all rally around and utilize. We need those mutually reinforcing activities. So the things going on and changing the built environment, those are all going to reinforce the health that we're trying to achieve. Continuous communication is probably one of the most difficult. And so I think the opportunities like this webinar that Morehouse and Together on Diabetes is sponsoring, these are the kinds of opportunities we need to use to talk to each other, to share information, use our websites, keep tabs, use social media, all of those things to help reinforce these activities and to have that continuous communication. And this notion of a backbone organization is something I would encourage you all to sort of think about. As you're organizing in your communities, we do need to have oftentimes an entity who will help keep the group glued together. It doesn't mean they're more important or they're the only leader or they're the only entity that's going to be getting the credit. It means that they are an entity that will help direct the orchestra. They will help keep the parts moving. In the case of the National Diabetes Prevention Program, CDC is serving in that role, and we really do that not again because it's an attention getting or because you want credit. It's because it allows us to be in a position to really facilitate and help. And I think that's really the attitude that entities who come in as backbone organizations need to think about, that it's that helpful role. So let me close there. Lots to talk about, lots to discuss with everybody, but I hope this has given you some food for thought on how critical it is to examine the research.
Questions from our audience, and I'd like to pose some questions as well. But for each of you, Dr. Albright,
and we need to continue to
starting with
measure
you,
and evaluate.
what does it look like at the community level if all the pieces are working well together? If the clinicians and the community stakeholders and the health promotion folks and the public health folks and the hospital folks and the YMCA, is there a health equity coalition? Is there an organizing group at the community level? And then how do they work together to really become seamless in achieving health equity for their community?
Yeah, that's really a great question. And I hope, and I would probably anchor some of that back to why I think looking at, again, there are various models, but this notion of a collective approach, a collective impact is needed, because a single stakeholder group, a single coalition is really going to have a very challenging time, because the things we're working on are multifactorial. They're multifaceted. They require a variety of stakeholders. And we need to be able to come together and sort of divide and conquer. And there are times where, yeah, we're all actually working on really the same thing. Again, that's that common agenda, but we're taking on different pieces of it. And so the ability for us to not have 9,000 versions of groups going on out there, the better off we'll be. But of course, that's a challenge, because the more people you get together, the more opportunity there is for different views, different opinions, different options. That's why, again, you have to sort of anchor back, I think, to some of those core elements. There are a myriad of things we can and should be doing. It's important for groups to determine how can they look at their communities, and we hope that the funding opportunity announcements that we put out from CDC are helping communities do that. We tend to fund at the state level, and then we also fund now at large cities. Those funded entities are intended to go out into communities and help them organize themselves so that they can indeed look at a large enough geographic area so that they will be able to have a public health impact. So I think it is these principles of collective impact for social change, and it's making those decisions about how to make sure that the groups you're participating in, we keep our eye on the ball, and we all practice some emotional intelligence so that we can actually help solve these problems. But the equity issues must be front and center for all of these kinds of endeavors. They must be infused into all of this work.
So in a way, it comes down to people playing nicely together to achieve a common outcome. Do you have some
Yeah,
thoughts,
I
Dr.
think
Gavin?
that's right. We not only need to play nicely together, George, but you asked the question of how does it look when it's all working together and it's seamless. I think we first look at outcomes and to see, are we achieving the desired goals with respect to leveling the health and healthcare landscape. And then that lets us know whether or not the components that drive those outcomes are working. And then we have to remind ourselves that we have to be intentional about the health equity piece. You know, we do a lot of education. We do a lot of education of patients. We do a lot of education of institutions and of providers. But part of the narrative that we must be intentional about is the fact that there is a major objective of achieving health equity. That's no less important than achieving the metabolic goals that are important in diabetes, hypertension, lipids. And so I think that we just can't lose sight of that. I think Ann put it in terms of keeping our eye on the ball. Well, that's a ball that we simply can't lose sight of. And no one size is going to fit all. But I think that what's important is that we learn the elements that are required, because what's working in Cincinnati, and Cincinnati is working extremely well, may not work in exactly that same form in Macon, Georgia. But the elements that have been defined, if captured and if integrated in this way that connects the dots, I think the outcomes will be exactly the same.
Fantastic. And you know, we often think about trying to improve public health or population health for everybody, and then health equity is an add-on. But if you think about it from a Six Sigma point of view, if you're eliminating unnecessary variation in outcomes, if you look at racial disparities as a form of variation that indicates that the system is out of control, then fixing that and making the outcomes better, perhaps for the most challenging sets of the population, or the sets that are having the highest disparity outcomes, will often force the system to become better for everybody.
You know, I would simply say, George, that maybe one of the things that all of us will be forced to think about in a more quantitative way, because we're now scoring everything.
Yes.
Well, you know what? We need to score the achievement of health equity. And make sure that that's on the report card of every place that's driving towards these outcomes.
Very good. Yes. Well, we've gotten a couple of questions from our audience about reimbursement and sustainability and the Affordable Care Act, and how is all that going to help? And so often we see these projects implemented with demonstration project grants, or then they're sustained on some ongoing portfolio of demonstration project grants. Are there models that we're seeing around the country where this truly becomes sustainable, where it becomes systemic in the healthcare system as well as in the community health promotion activities, so that either it pays for itself or the investments are ongoing, and we're not dealing with one patient at a time in the exam room mode of reimbursement? Dr. Albright, do you have thoughts about that as you see some of your grantees finishing up funding cycles? Where do you see us landing in terms of ongoing sustainability?
Yeah, given more time, we would have given much more of that information around the National DPP, because from its inception, it has been the intent of that work to actually be involved in that. And in fact, the National DPP has been built on in doing just that. There is a reimbursement model in which we have, from day one, been working with commercial insurance companies. Now, not all commercial insurers are on board yet, but depending on how you want to count those insurance companies, there are at least 12, and again, United Healthcare is one of them. They have several different markets. Some people count each of those as individual markets. There are Blue Cross Blue Shields coming on. There are a number of regional health plans coming on. So we have said from day one that it really does need to be done in that way. Because you cannot support this on grant funding indefinitely. How we've been using those dollars, and it's true in the new funding opportunity announcements that we put out, that locations can use those dollars to build, in this case, the national DPP for up to 2 years, because we want to give groups time to build their capacity, get their systems worked out, get things in place, but that can never be a long-term sustainable source of income. It's again an example of community clinical linkage, because we are linking these community delivered interventions to the reimbursement system. And it does again mean that we need to show outcomes. It's why the standards exist. They are a huge driver, because no one wants to be paying for something that's not effective, nor should we be tolerating things being paid for that are not effective. So that has really been our model, and it is what we are seeking to do in much of the work we are doing going forward. It's been new for a lot of folks in our world to be interacting with these commercial insurers. We are working with Medicare and Medicaid, and we're optimistic that that will also come online down the road. But the more we're all organized and uniting around this, the better off we will be.
Very good. Well, we've gotten a question or two about how do we train clinicians around clinical inertia? How do we train clinicians to be more sensitive? Often clinicians may come in with a perspective that I just have to know the medical protocols and I tell the patient what to do, and if they don't do it, then they're non-adherent or non-compliant. And obviously, we almost need a whole new way of training clinicians, and then perhaps we even need a whole new workforce when we think about team-based approaches that extend beyond the clinic walls into people's homes and communities, the community health workers and so forth. Dr. Gavin, do you want to think out loud a little bit about the workforce and how we train people to do what's really needed on these team-based approaches?
Yeah, I think that what I'm seeing is encouraging, because the team-based approach is now becoming more real than virtual, because it's clear that it takes more than a village to really drive towards some of these outcomes that we've been talking about. And in the chronic care model, one of the things that you see just before you see improved outcomes is you see the interaction between an informed, empowered patient, but an engaged and knowledgeable professional. And it's meant that those two things will occur in parallel and interactively. So when we talk about how do we keep continued training in place so that you don't have chance to lose sight of what the important elements are. Everybody's got to be serving as a constant reminder of the fact that when goals aren't being met, we have to do something. Goethe said it well. It said it's not sufficient that we know, we must do. So act on the knowledge that we have. And so that's why I think that in what I see in Cincinnati, for example, that Aligned for Health, where it's more than just getting people into systems of care, but driving towards a culture of health where everybody is on the same page with respect to accountability. The providers are responsible for making sure that the patients who are also engaged and activated, that their interests are addressed and that their needs are being met, and that you don't carve out a little piece of this and it's yours and the rest of it belongs to somebody else. But when it's the team, there's only a one W. That's a win, and that's assigned to the team, or an L. It's not assigned to an individual on the team. It's the team's score. And that's the mindset that we're trying to drive towards when we're building a culture of health. And there are plenty of examples of that. Unfortunately, we don't have as much time as we need to do a deep dive.
Sure. Well, and one thing I do want to pick up on, though, is because you've mentioned this twice, is that sense of accountability and the willingness to measure your outcomes and then admit when you're not moving the needle. Acknowledge that this was a wonderful program. We all had great meetings. We did some cool stuff together. We got hugs from patients, but the A1Cs didn't move, or the amputations didn't change, or the other bad outcomes that we're worried about didn't change. And we then hold ourselves accountable to trying something different, to do something better based on those outcomes feedback loops, and to have that data in place. And Dr. Albright, do you want to speak to this a little bit? It seems like many communities are having to try to build this one community at a time, getting data from their local hospital or their payers. Do you see on the horizon a way in which we can systemically change this across the United States so that outcomes data that are relevant to health equity at the local community level automatically to clinicians as they practice?
I think it's certainly things to aspire to, and we do need to continue to refine the data that we get access to. I think, as you can well imagine, you all know you're involved in this. It's a challenge because we are balancing the ability to get data and personally identified data. There's a lot of sensitivities around that. Who manages that data? There have been groups, for example, in New York City who did an A1C registry that was managed by the city health department. That was met with differing views on how appropriate that was and how is that data being used. But I think, again, it's important for us to continue to keep our eye on what we're trying to get done. It is important for us to realize that we do need the information. We do need the data. There are different kinds of data. They tell us different pieces of information. And then we have to wrestle with things like how much information is enough information. To your point, when do we decide it was a good idea and now we need to actually redirect our efforts? We should take those as learning opportunities because we now know probably not as effective. We need to understand exactly why then it wasn't effective. I think sometimes people look at the information they have gathered and they think, oh, well, you know, that didn't work. Well, do we really know that it didn't work? Did you actually give it enough time? Did you give it enough sort of volume of what you're examining? But this notion of these large data sets, a large national, we've had a lot of people ask us questions about registries, particularly for youth. Will there be registries and how do we get down to that local level? The data instruments that we currently have don't allow us to get that fine-tuned, but there's lots of discussions right now about these data sets from health plans, from EHRs. A lot of these big data sets are now being examined. So I think it's an area wide open for a lot more investigation and exploration, but it is on balance with these issues around privacy and sensitivity.
So much rich knowledge in this room, and with Dr. Albright over at CDC, thank you so much. Dr. Gavin, thank you for being here with us. I wish we had more time to explore this further, but we will continue these conversations in further webinars. You can also visit diabeteshealthequity.org to see some of the best practices that we've cataloged already, but we'd love to hear from our audience of best practices you know about that we haven't discovered yet, and to get those up on the site with stories about the best practices, as well as the tools and templates and resources that people are using to make a difference so that we're not all having to reinvent the wheel. We want to thank all of you for participating. Ms. Sabrina Jackson is going to have some further instructions for you, and there will be an opportunity for communities to participate in a much more intensive learning collaborative in the coming year, and we hope that you will seek out that opportunity as we go forward. Sabrina?
Thanks so much, Dr. Rust. And thank you again, Dr. Gavin and Dr. Albright, and to all of our participants today. If you notice on your screen, there is an overview of the Learning Collaborative that Dr. Rust mentioned. It's so awesome to hear Dr. Albright and Dr. Gavin to mention and talk about collaborative care. That's exactly the gist of the Learning Collaborative that we will host and sponsor beginning next fall. So please click on the link or visit us at diabeteshealthequity.org. Across the banner at the top, you should see the Learning Collaborative, and there is a one-pager that gives you information, as well as if we advance the next slide, you can see upcoming dates. So we'll be having a webinar in early January and also mid-February that talks about recruiting with our application process. And if you continue to look, you'll see when we'll be putting out the applications, when the decisions will be announced. So please, please, please stay tuned for that. For those of you in the